participated in the workshop yesterday and made a neural tube defect, they are out at one of the tables for right outside where all the food is. And so if you want to stop by, they're in little plastic bags and they have your name on them. So please stop by and get your neural tube defect to take home with you. Things that you thought you would never say, yes.
Okay, where's Naomi? Okay, this is a
Clicker.
yeah, just
Great.
forward back.
Okay.
You don't touch these two.
And that's the timer. Great.
And that's
Wonderful. That was the one.
Yeah, all right, here we go. I know everybody's having such a good time visiting, and but we need to get started for another great session. And you know, one of the purposes of this meeting was to get together people in an informal atmosphere, people who are interested in neonatal resuscitation, and share ideas and their enthusiasm, and I can see that happening, and it really makes me feel like we've accomplished the purpose of the meeting. So I'm so happy everybody's here, and we have such a great series of speakers and discussants. And my privilege right now is to introduce our next speaker, Naomi Laventhal. She's a neonatologist and a clinical ethicist, and she went to LSU and then the University of Chicago, did her peds and neonatology there, and then she did a master's in ethics, and then she did a master's in policy, and she finally got a job at University of Michigan at Ann Arbor, and she is now the chief of the division. So she has all the problems that Satyan has brought up in terms of money and people and all those kinds of issues. But her clinical and academic focus has been on ethics, on consultation and care coordination. And she has a neonatal ethics lab that serves as the hub for pediatric ethics at the University of Michigan. And she, I think, just finished her term as the chair of the American Academy of Pediatrics Committee on Bioethics. So we are really happy to have Naomi join us here. Now, the fun fact about Naomi is that she was a barista in New Orleans before she went to med school. So I welcome Naomi to the podium. She's going to talk about perinatal ethics and care coordination for infants with complex congenital anomalies, which kind of goes along with our workshop yesterday. So here, Naomi, take the mic.
Thank you so much. It's really a pleasure to be here. And I had such a good time last year, and I was so flattered to be invited back. It's particularly flattering to be invited to someone else's group. You know, this is an area that I don't know that much about, and I learn so much when I come to this meeting. I'm just thrilled to be here. But I am going to start with some sort of notes as an interloper here. One thing I want to acknowledge to everyone in this room, even though we spend our academic lives doing different things, is that for all of us, decision-making and care coordination for these really complicated babies who have either really unique or complex anomalies or constellations of anomalies, it's some of the most labor-intensive, undervalued, and poorly compensated work that we do. Building and maintaining relationships with our obstetric partners, with pediatric subspecialists, with surgical subspecialists, building relationships with parents over the course of a pregnancy, and with our resuscitation room teams in the delivery room. This is really important and skill like everything else that we have to build with commitment and practice. I also have been reflecting over the things that bioethicists and resuscitation scientists have in common. And this was acknowledged as this session got started this morning, that we advocate for infants and families. We do that by a really specific niche. And time, we've gone from doing this by kind of consensus to doing this with really robust literature that kind of supports our thing, right? I've asked a lot of people over the last couple of days, what's your thing? But it supports our thing as an evidence-based skill. And that skill applies over things that are really routine, ordinary, and practical to things that are really extreme and cutting edge and innovative. And so it's always enjoyable for me to think about the things that we have in common over different areas of expertise. So I learned a term from Clara. I used to call this the TLDR, but now I'm trying it out as the BLUF, the bottom line up front. Thank you. I always lead with kind of my punchlines, especially because I sometimes run out of time. But the first, if you sort of take nothing else away from me as a bioethicist, it's assume good intentions in these really morally thorny situations. People come to work to do a good job. Parents come to these scenarios to be good parents. And I think one of the places that we go wrong a lot is thinking that people won't do what we want them to do when they actually can't do what we want them to do. And sometimes when we can't get parents to the place we want them to be, it's because they can't get there. Good ethics start with good facts, and I've spent most of my career thinking about that from a standpoint of epidemiology. We have to be able to describe the outcomes of these populations to make good decisions for the infants, but this also comes from listening to people, listening to our colleagues, listening to our subspecialists. For me, I've learned a lot from listening to obstetricians, but also listening to families, and the power of the phrase, tell me more. It will help you over and over and over again, filling that awkward silence, tell me more. Can disagree on what constitutes a good outcome. And reasonable people can hope for a good outcome even when it's really unlikely. Perspective taking is, I think, something that can help all of us get through our longest call shifts, right? We take in-house call at my institution, and sometimes you have those moments of, will the sun never come up, right? But for me, thinking about, I'm not the one having the worst day. And in a lot of situations when I don't know that I want to keep doing it, it's not me that's having the worst day. And finally, our job is to tell the truth, but not to bludgeon people with it. And this quote from Maya Angelou that probably most of the people in the room know, but people will never forget how you made them feel. And that's so much more important sometimes than getting your facts really precisely correct, is delivering them in a way, because that will stick with people for the rest of their lives. All right, so I'm assuming that most people here have had some exposure to basic principles of medical ethics, and I'm gonna phrase those here, I'm gonna refresh them, but in the context of the delivery room and these complex resuscitation decisions. So good ethics start with good facts. I'll say this probably several more times. But so when outcomes are unambiguously good, or even when they're likely to be very good, we provide anticipatory guidance. That is the bread and butter of what pediatricians do. We provide anticipatory guidance and we save the baby, right? That's beneficence. When you can save the baby, save the baby. When outcomes are uniformly bad, we provide anticipatory guidance and we provide comfort care. That's non-maleficence. We don't go into resuscitations where we know we're not getting out. But when the quality of the outcome is subject to interpretation, or that outcome is really hard to predict, that parental preference, the values that parents bring into those decisions, become really quite salient. That's shared decision-making. And shared decision-making is easy to say and hard to do. Reasonable people, again, can disagree on what a good outcome looks like and how likely it needs to be worth pursuing. You'll notice I've said this twice already. One thing, though, that I'm saying more and more is that differences in what we offer and what we require and what we recommend should stem from the relevant context, what we know about the parents, not assumptions that we make about people, not differences in access that they have, not the values we impose on them. This is justice. This is fairness in the way that we practice, is tailored care to the situation, not to sort of unfairness in how people got where they are. Some people have probably heard me say this before. Every now and then there's a figure and you're like, I wish I had made that figure. I wish this was my figure, but it's not. I think this is one of the cool figures in pediatric ethics that really lays out this whole spectrum of parental authority. We talk about parental authority now, not parental autonomy. They're kind of a different activity. But it really sketches out visually, I think, this scope of decision-making where when outcomes are good, we act on the baby's interest to provide care that helps them. When outcomes are really bad, we don't offer those things. But in the middle, when interventions are investigational, when outcomes are really uncertain, we give parents a lot of authority over those decisions. People have called that the gray zone. The nice thing about this model is that you can apply it to a lot of different situations. And even in my career already, we've seen, for example, at the margin of gestational viability, the boundaries around this can move, but the concepts are the same. And this is often referred to as the zone of parental discretion. And I did not know that Jeanne Krick was going to be one of the discussants when I put this slide up, but she's done some really brilliant work around this, normative work, talking about the best interest standard. And one thing that's also changed, someone asked me on the bus today, what's changing in ethics? And I was brought up in this world that the standard was the best interest standard, and that parents weren't allowed to sort of fall below that best interest standard. I think we're learning now that maybe that's not always the right standard, and that we can, within a sort of variable zone, depending on the situation we're making, really let parents make decisions that we don't love, right? And it's okay for parents to make decisions that we don't love. It's certainly okay for parents to make decisions that we wouldn't make. And when I work with trainees who are really struggling, one of the things they'll say to me is, but I would never pick this. And I'm like, that's okay. You're not the one picking it. And so this idea that parents have the latitude to make these decisions and that there is some floor to that, right? There's some bottom to this zone of parental discretion where we say that's a harmful decision that we're not going to let you make. But I think it certainly makes for being a happier physician, nurse practitioner, whatever your role is in the NICU, if you can allow for some space in this range of decisions that we let people make. Especially around uncertainty. But again, in highlighting some of Jeanne's work, we really hate uncertainty, you guys. Like, we really hate it. And we particularly hate it early in our careers. There's this interesting phenomenon when trainees come out of their fellowships, they like really hate uncertainty, and then they get a little more comfortable. They hate it again. But throughout their careers, many neonatologists just hate this idea that they can't predict with a lot of precision what's going to happen. And to me, the answer to this is you stop fighting it and you lean into this fact that we can't predict the future very well, and that probably most of us just get comfortable with it. We don't get better at predicting what's going to happen. So this is a term I made up called prenatal consultology, right? You guys are resuscitationologists. I'm a prenatal consultologist. You get old, you can make up words. It's really fun. Stick around. And I am not usually a let's build this around a case thing, but this happened to me literally on Monday, and it was such a good case of the kind of complex prenatal consult world that I live in that I'm going to use it. So I was hanging out in the car at soccer with my laptop in the car, trying to work while my kids are at soccer practice. And the weather, it's been great in Ann Arbor lately. But so this is a verbatim text that I got from my fetal cardiologist colleague. No rush, just a question for you to think about. There's a fetus with Yule's anomaly, which is parchment RV, it's 26 weeks. Think about this as the worst Epstein's ever, but it's the RV, it's not the tricuspid valve. The fetus already has high drops, not too bad. High drops, or is it high drops? And already having some tachyarrhythmia, it could be VTAC. Okay. At what gestational age would you think that the delivery with the goal of intervention would not be futile? And I read this text and I read it again. and I'm all right, I'm not gonna answer this. This is truly a screenshot from my phone about this. This is not contrived. And I put this pick up the phone. Pick up the phone, talk to people. This is something I try to teach my trainees, pick up the phone. You cannot do this over secure chat, pick up the phone. So we talked, and this is also for me, I enjoy these conversations. I find it really gratifying to think through this. This is where I got stuck. Okay. Sometimes this video works and sometimes it doesn't. There we go. One of the things that's really struck me as I've moved away from margin of gestational viability to anomalies is that these are diseases that we've known about for a long time, right? I mean, we know about myelomeningocele, we know about gastroschisis and omphalocele, we know about CDH. These are conditions that we know, but what we're doing now is diagnosing them earlier in gestation with more and more kind of individualized precision. We know what's causing them. And that's really changed our interface as we lead into these complex resuscitations, because we know a lot about these babies before we meet them. We also know their names, right? We know a lot more about these families and these children as we go into these resuscitations. Which did not mean I knew a ton about Yule's anomaly. I don't know if any of you have ever seen this. It is exceptionally rare. It's so rare and there's so much fetal demise around it that no one really actually has a good point estimate on it. But you have this sort of useless right ventricle with no myocytes. This presents with severe cyanosis at birth. It's at risk for this VTAC, and it was wait, VTAC, that one, the wide complex, that one. And you basically, if you're lucky, can get through a 3-stage palliation with an aortopulmonary and a hemifontan and a fontan, some likely to end up with a transplant anyway, and in some cases, some people think you probably should just go straight to transplant. It's a bad disease, right? Which nobody has any experience with it because it happens like never. In this case, I learned some more things on the phone with my fetal cardiology friend. What is a circular shunt? I was like, can you remind me what a circular shunt is? So basically, this is just sort of going around in a loop because the RV is so dilated and dysfunctional, and there's some evidence from Epstein's that you give the pregnant woman ibuprofen on purpose to try to make the ductus smaller is a thing, I guess, that you do sometimes. And if you're having palpitations, I was having palpitations. So I'm starting to sweat, right? I'm thinking about this, and I'm supposed to give some answer about this, like fetal high drops 26-weeker with this terrible disease, and when are we going to offer something? That's probably the question I get the most often is like an advanced consult question, is when are we going to offer something? So one way to think about this question is, what gestational age are we going to offer something? What I don't know what reasonable means, but if this baby was plunked down on the warmer in front of you, when would you offer something? And this comes up a lot, and I would say that is a much easier question to answer than when should the OBs cut this baby out, right? I think that's a much harder question to answer because that has all sorts of implications for the pregnant person. But either way, it gets down to this, can we predict the outcome for this baby with any precision at term, much less at some very wide spectrum of gestational age? So I started asking questions, and they were 20 questions, just like as they came to me. But so what does this look like in the best case scenario? And I already kind of told you that. You sort of embark on this single ventricle palliation pathway. A question I ask a lot, in the best case scenario, would we offer comfort care for this disease? And I got a sort of unequivocal yes. What distinguishes this case from that best case scenario? And this is where it gets interesting because the cardiologist is like, well, I don't really know because I've never seen this myself before, but it seems kind of bad that we're already seeing high drops in the arrhythmias already. Do we think there's any chance of this patient getting to term, right? Probably not. And what do we already know about this family? Do we know what they want? Do we know what they have been told about this? Do we know what they're afraid of? Do we know that we're hoping for? And I won't get into all of that here, but we had some sense that this was a family that already made a decision to try to get to some state in this pregnancy where they could deliver a baby and get to a trial of therapy, but that they were fairly realistic about how bad this was. So I'm chewing on these questions, and then it starts to crystallize, and I'm finally kind of getting to the questions that I think are going to actually help me. What's the youngest gestational age that our surgeons are willing to actually embark on this single ventricle journey? And the answer is, look, I don't exactly know. It's probably somewhere in the 34 to 36 weeks. Question we can find out, right? We can call our cardiac surgeon friends and find out. Is there any scenario where this is one of those, park the preemie in the NICU on PGE and get to that gestational age if this baby is born before then? And this is where the cardiologist was like, no, I can't imagine any scenario where we can bridge a baby with, recurrent VTAC and no right ventricle to sit around waiting to be big enough. So that's a really helpful piece of information. And then we start talking, is there any situation where this baby is born in extremis and we can stabilize this, right? If you're doing a crash C-section for fetal distress, learned a lot about chest compressions in the last 2 days. If this baby is getting chest compressions in the delivery room because they come out so badly, is that a situation where we can pile on all these other things and hope to stabilize? And we're thinking, this is really probably not that situation, right? Where if we add on sort of instability in the delivery room, that we can help this baby. So where we landed is where we usually do. Let's have neonatology and palliative care see this baby together, this mom together. And we had not talked to our OB colleagues yet, but we thought, this woman should never have continuous monitoring because we never think a crash C-section is going to be a good idea. And we should really not be offering a trial of therapy if we're not being born at an age that we can go immediately to that staged palliation. Given the likelihood for high drops, we should really be using a gestational age threshold for surgery and not a weight threshold for surgery because high drops messes everything up with weight. And once we get to that gestational age, maybe that's when we start talking to the OBs again about does serial antenatal testing help find that sweet spot of we're not in extremis, the baby's not crashing, let's deliver now because it's as good as we're going to be. And this baby's never going to tolerate labor. So we have to talk about a cesarean delivery for this baby. None of this had been vetted with OB at the time I put the talk together, but it will be. So my point in sort of belaboring this case is that although I've harped and harped in my career about understanding population outcomes, sometimes you're not gonna have them, and sometimes you don't actually need them. Although we use that prognostic information that we have and that precision can help families decide whether or not they want to pursue interventions, and the implication there is that unsuccessful intervention is more harm than good, right? It costs the baby too much to try this if it's not going to work. That's how parents make value-sensitive decisions. Sometimes our job is to think things through. I talk about this with my kids all the time. Let's stop and do a think through, right? Every morning before they leave the house. But like, let's just stop and think through the practicalities of planning this delivery. And that's been my road with prenatal consultation as we moved from what most of us learned in fellowship, which a prenatal consult for margin of viability, which has to do again with understanding the obstetrics and teaching and training it and teaching health communication and what we call relational competence, and thinking about things like, do we use a rule-based approach or an individualized approach? We talked about this, I think, at dinner. To counseling around single system malformations that we can do something about, and things like complications of multiple gestation. We do a lot for like, when is this patient with a MOMO pregnancy gonna come in for monitoring? Thinking about our patients who get lasered for twin. And now we're in this world of really precise prenatal, the world of like prenatal whole genome is here. This very complicated world that people are living in this like ever-changing world of reproductive decision-making and access to reproductive interventions. And just this infinite spectrum of severity and diagnostic certainty, right? Like some of these things, if you've seen one, you've seen one. And so we don't have the NICHD outcomes calculator for these things. We don't have this ability to really query data to know what the outcomes are. And we don't have these jazzy tools, right? We don't these like sort of validated, like a pictograph like this is a validated way to show information to people. We know that they improve gist knowledge and verbatim knowledge. Like if you're gonna show people statistics, this is how you do it. We don't have a pictograph for some of these things. We just can't do it. And we don't, this is a graph I made with Marilyn Arnold, who's one of my colleagues. Like here's to how you do a prenatal consult for margin of viability, which should allow people flexibility to be themselves and talk the way they talk, but also offers very specific suggestions. We can't rely on this. And this is important because we've recognized as a field that we were falling down in how we prepared our fellows across multiple disciplines to do this when they left fellowship and went out into training. And we surveyed program directors from multiple disciplines about, are you teaching your fellows how to do prenatal consults? And the answer was no, and unsurprisingly, when we asked, do you think that your fellows are graduating knowing how to do this? The answer was like, also no. But people have really moved on to sort of generating these cool toolkits for teaching and evaluating how you do antenatal counseling, almost always grounded in margin of gestational viability. And the world of prenatal counseling around congenital anomalies is much younger, but empirical research methods, and I'm just gonna say this because this gets lost sometimes, qualitative research is still empirical. It's not quantitative, but it's still empirical. You're still using data to answer a question. And some really nice qualitative studies are coming out around how parents perceive prenatal consultation for congenital anomalies. And what they say is it helps to sit down with someone who's going to talk to you to see that they helped you think through what it was going to look like, but they really do want to be given that opportunity to be hopeful, even if the outcome is probably bad. And that comes out in study after study after study, that people don't just want all the bad news. But preparation, what's it gonna look like? And not just like, is my baby gonna live or die, but like, where's my partner going to stand? When are my parents gonna get to see the baby? Will I still be able to breastfeed? All of these things play into that preparation, not just how does the ECMO circuit work, right? But things just about like, how am I gonna parent in this environment? And other specialists are starting to work in this area too. So this has been studied among pediatric surgeons. How does their interaction with these families sort of play out? One of the things that comes out is things we all already know, but we're starting to write down, like in this study of parents who'd met with pediatric surgeons around congenital anomalies, almost every single one said some way this anomaly is my fault, right? And so if you can find a way to elicit that as part of your consultation, even if that's not why you were there, and to like give them an opportunity to air that like it's their fault and tell them it's not, right? So there's just now this explosion of research around the role of prenatal consultation coming from just about every specialist you can think of. There's research on using telehealth to do prenatal consultation that came out of the pandemic. There's research on counseling about breastfeeding during a prenatal consult, shockingly improves breastfeeding after birth, right? And so in bringing this up is that this is a trustable skill that we should be teaching and studying and finding best practices about. All right, I'm gonna change gears completely. In my sort of quest to involve myself in the world of prenatal consultation at University of Michigan early in my career, I found myself embroiled in some other stuff that was much more practical, just around like planned deliveries, which really isn't about ethics, but is about teeing these deliveries up. And there's some interesting posters about this in the session. But what I learned about this is that leaning into like quality improvement methods and simulation and collaborating with colleagues makes our healthcare delivery better, makes things better for families, and generates scholarship and like saves the hospital money, right? And this started for me looking at these critical cardiac deliveries. And this is one of those things that's a little hard to generalize because every hospital is set up a little bit differently. But we were really struggling with these race to the cath lab deliveries. And they were both about this is just a kind of schematic of our hospital, but like we couldn't figure out which floor to deliver them on to ever be where we wanted to be. We were on somebody's turf. We couldn't figure out who was in charge of the resuscitation, and we would have them. And even if the outcome was okay, we felt bad. Nobody felt good after these deliveries. And we were teeing up for one of these scheduled C-sections for something in tech septum. And we were like, we're gonna get it right this time. We are gonna figure out how to do it this time. And it's worth a lot of energy and time to figure it out. This, by the way, I love this term, the HALO, high acuity, low occurrence event, right? And like burned into everyone's subconscious is the value of simulation for a HALO event. And what we did is we just talked to everyone, and we got everyone in a room who was gonna touch this delivery. Said, how do we do this? And what came out of this was, first of all, this like exceedingly granular checklist of the things that had to happen. Who was showing me? I think George showed me last night the run of show. No, somebody showed me the run of show for this meeting, right? We planned this out with this huge level of specificity. And for the next few that we did, we simmed it every single time. So every single time we had one of these coming up, we'd get the actual people who were actually gonna be there, and we simmed it. And this is not hugely robust compared to some of the things that you guys do, but we like cut the time to cath lab in half. And cut the variability in half by just practicing in a somewhat informal way to just make sure that the people there knew where they were supposed to be. So this kind of fueled my interest in this, but these are really rare, right? Like, this doesn't come up that often. But we started to think about congenital heart disease deliveries, and what about when there's a lot less on the line, but what's on the line is things like that parent's experience of that birth, that OR that we've tied up for a primip having a low risk hypoplast being born and delaying all the C-sections. And if you've ever like been waiting for your elective C-section for that to happen, you're really annoyed, right? It costs more money to turn over an operating room than it does to turn over your L&D room. And we started thinking about those patients where these are the patients that we accidentally sent home before CCHD screening. And are we doing right by those families? And why are we reinventing the wheel every single time? And so what we started thinking about was this concept that we called supratentorial CPAP, or just like, why do people freak out in the delivery room when it's the heart and like give oxygen they don't need and give CPAP they don't need? And so we took a cohort of historical babies with congenital heart disease and looked at who got respiratory intervention in the delivery room. And lo and behold, when they did, it was usually because something else was going on. It was not the heart, right? It was the fetal distress. There was a risk factor for sepsis. There was something else going on that we could identify that drove that need for respiratory support. But if you could isolate the babies who really only had congenital heart disease, they were fine. And this was like not a publishable study by itself, but what it did do was reassure our own institution that we can pick out the babies who are going to be in trouble from the ones who are going to be fine. And so the first wave of this that we did is we created some like dot phrases for our epic around the notes that the fetal cardiologist would use to sort of guide the delivery team in anticipation of these births. And the very simple thing we did was provide the neonatal resuscitation team with the anticipated saturation. And we said, the world is not your oyster. You have 3 choices: normal for gestational age, greater than 75%, or whatever you can get. those are your choices for saturation, and everybody's notes had to look the same. And we started standardized. Fetal cardiologist wrote the notes, and we made people stop giving respiratory intervention. People stopped giving oxygen in the delivery room when we just told people what to expect. I mean, this is like free intervention, right? Zero funding, zero money, but people stopped giving respiratory intervention. And we started seeing that parents were also getting to hold their baby in the delivery room because they weren't attached to CPAP that they didn't need. I mean, the CPAP difference is actually not statistically significant, but people weren't hovering as much because they knew the sat normal. So yeah, it's all right. So then we were really, really jazzed about this, and we started thinking about what can we do next? And we started thinking about developing a risk category stratification. And we looked at all these like leveling, so like NICU levels, like 1 is low, 4 is high, trauma center levels are the other way, DEFCON levels make like no sense. And my collaborator remembered this thing from the Homeland Security, the terror meter. This is real, this is not made up. This is how the Homeland Security does it. And so we decided to go with this like kind of rainbow color thing, and really worked through, again, like this pragmatic thing about, from the perspective of a cardiologist, this baby is gonna be born, what do you want them to get, and when do you want them to get it? And we reminded people, like, here's when the ductus closes, to sort of like guide your thinking about what you want them to have. And we sort of mapped that to these colors, and you don't have to like burn this into your memory, but the idea was like, do you want something, how soon do you want it, and how sure are you? And that turned into this mint thing with our cute little like, it's a graphic element, it's not a logo. U of M is very specific about what gets to be called a logo, but it's a graphic element. And we made this color-coded thing, which guided who went to the resuscitation, where the resuscitation occurred, and sort of when cardiology would get involved. And we started doing our drop-down notes, like the text color is in like the color of this category. And really started flagging like this is an orange delivery. And it was the orange category that was really the big deal. Because kids, this is a bad disease. This is potentially a high mortality disease. These babies are gonna go to the cardiac ICU. Satyan, ours even go pre-op to the cardiac ICU. This is a hypoplast, but this is a baby that could fool you into being well. And this is a baby that can have a hour period where they're unhooked, they're not monitored, they're with their parents, they can have non-nutritive breastfeeding. And so this is the appropriate use of looks good from door, like we would send our resuscitation person, be like, all right, an hour. And if there's anything about that baby that said, I don't feel good about leaving you, then we're gonna take the baby and assess, but that family got an hour of intact family time. And this is important because if you take like all-comer hypoplastic left heart, the mortality is still reasonably high. And these are parents who might not be again without wires and tubes for weeks, months, maybe ever. And this was a big psychological hurdle for our unit. But it's worked so well that we now do it for non-cardiac surgical anomalies as well. And part of the reason is because we partnered with QI experts. I am not a control chart person. I've had to learn what these mean. But I think you could argue these look pretty good, right? I mean, this is babies who are held in some way, documentation of parent bonding time over the course of our interventions. And the even better looking one is the ones who didn't get any respiratory intervention. And so, I'm like a squishy bioethicist. I like control charts, but I like text messages clearly. So this is one of the first ones we did where the OB said, this was what you did for this family, to let these people hold this baby and have this hour, right? So this is to sort of say that the world of prenatal consultation isn't just about making morally hard decisions. It's about looking at the way families function in the face of this increasingly precise prenatal diagnosis and thinking through how do we support these families? How do we understand this disease? And how do we bring scientific rigor and QI methods to what we do and get it out in the world? I also learned, by the way, that if you have a QI poster at PAS, you get automatic Part 4 MOC. They just come and give it to you, which is really cool. Okay, so I'm gonna take a breath because I'm a fast talker and move on back to more of my world, which is probably more of what y'all would expect to hear from. And this is a term I've started using a lot, which is that the less things change, the less they stay the same. And this gets to the idea that I brought up at the beginning, which is these diseases aren't new, but the way we think about them sometimes is, and the way we're approaching these conditions has changed a lot in my career and your careers, and it's gonna continue to change. So for a chance at a bonus, what am I gonna talk about? Right. So trisomy 18 was first described in the literature in 1962. We have known about trisomy 18 for a really long time. And unlike some of these other conditions, we've known about the genetic cause. We've been able to diagnose this with precision for a long time. And certainly when I trained, we were using the term like lethal anomaly, right, was the language we used around trisomy 18. And some cases early in my career after fellowship really started to challenge both how I thought about prenatal consultation, but also how I thought about these conditions. This was in the age where people still had blogs. This was before the kind of like widespread uptake of different kinds of social media. But I saw a family that had come from Ohio, and the Ohio-Michigan rivalry is so intense. As someone who's not a Michigander, so this behind the enemy lines thing was this family that was like, I had to go to Michigan to get my advice, and can you believe I had to set foot at U of M? But it's not in my blood to care about this, but they had a fetus with trisomy 13 who had congenital heart disease, and they were considering neonatal congenital heart surgery and trying to decide where to deliver. And the added complication here was that they only had, their insurance would only pay for kind of like one trip to see us. So we had to get all the ducks in a row to get all the consultants in the same room at the same, make multiple trips. And so we had to find a conference room to do this, and we got everybody. But this was what the mom wrote in her blog about this visit of we got everybody together, we got all these people, and they were prepared, and they knew about our baby, and they'd taken the time to understand what we wanted and know our baby, right? And this, to me, I used this in my lobbying to get more resources for our program, because this is also free advertising, right? This was out on the internet. And they didn't end up delivering with us. They delivered closer to home, which was probably better for them. And that baby had congenital, died during that initial hospitalization. And I think that family regretted that decision zero. But it started to really color how I thought about these families. And we had a few cases like this that I'm looking at Gary, because Gary and I know the same case that I think challenged both of our thinking about this. But the world of trisomy 13 and 18 has changed dramatically in our careers. And if you look to the internet now, you see a lot of different things, including this photographer who takes pictures of medically complex children and sometimes uses their tubes and wires to be parts of the pictures and stuff. But this baby looks pretty good and is not a new was trisomy 18, but there are health surveillance guidelines. The Society of Thoracic Surgeons has developed some sort of evidence. They use that grading of evidence scheme to sort of make some recommendations about this. And all this culminated a month or two ago, in this project that I've worked on for the better part of a decade to bring this AAP guideline out about the way we talk about, plan for, initiate care for infants with trisomy 13 and 18. And I think this really hopefully brings around that point of this doesn't have to be about you, what you would pick for your family, for your own kid, what you advise people to do, but applying ethical principles fairly in the way that you would for any other condition with similar features. And one of our sort of recommendations at the end is, although exclusive comfort care remains a morally acceptable choice that should be offered to all parents of infants with confirmed or strongly suspected trisomy 13 and 18, this diagnosis alone does not justify unilaterally withholding therapies. And that was not an easy recommendation to get into print. This was, in my institution, we've been practicing this way for a long time. I suspect in some of yours, that's true also. And I suspect that some of them it's not. But our take on this was, you were going to counsel about this. You're going to counsel honestly and clearly about the prognosis that we know of for trisomy 13 and 18. But withholding therapy from looking at that particular infant's constellation of anomalies, looking at the known outcomes. For example, we know that the survival outcomes for single ventricle palliation with trisomy 18 are really, 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 and it, at this point, seems justifiable to not offer single ventricle palliation for trisomy 18. That's an individualized decision. Also, counseling as though the baby didn't have trisomy 13 and 18 doesn't make any sense. We're not going to do that. This is a lethal anomaly and we don't do that, is behind us. One other thing I want to point out about this statement is that I was looking at this obviously no one could read this table, but this is a table we had about how to sort of plan for these deliveries. And I highlighted a couple of things here about making a plan for coordination of subspecialty consultation. Consider how all these subspecialists are going to work together. Consider the timing, aim for someone who's going to hold some continuity over the course of this pregnancy. Consider whether integrated or sequential timing works better for this family in your institution. Pick genetic tests and timing of those tests that fit goals of care. Make an obstetric plan that makes sense, that fits, distinguish fetal intervention from maternal interventions. One of the things that we see time and time again is women refusing delivery to save their lives because they're afraid that we won't save the baby, right? And when that happens, you've done something wrong. You've really not resuscitation the right way. And pick a delivery hospital that is going to be able to deliver the care that fits with that family's goals. The reason I have this here is because this is no different than I recommend for anybody else with a complex set of anomalies, right? This is in the Trisomy 18 statement, but this could be anywhere. So I'm gonna wrap up. How should we approach the resuscitation of infants with complex congenital anomalies? And what I've learned recently, having spent a lot of time in the NRP books, it's really fun to use Gary's, by the way, because they're like signed by all of you guys. It's really fun to use his. But this is an NRP. Anticipate and plan, communicate effectively, use available information, call for help when you need it. It's so important. Maintain professional behavior and know your environment, right? This applies to these gnarly, morally fraught situations in the same way that it does for a 24-weeker, in the same way that it does for asphyxia and meconium aspiration. It's the same principles. And then here are my squishier Naomi ones. When you go into these deliveries, it sounds silly, but I say it a lot, and I think to me it's helpful. Be smart, be safe, be nice. And then this, plans are worthless, but planning is everything. I think that this really does apply to these situations. Check your assumptions and biases and get the best objective information that you can get. Expect unknowns and unknowns. One of the things in conversations about this, it all goes fine, and then they're on vacation in the Upper Peninsula when they go into labor, right? I mean, like the things are gonna happen, then they're gonna have choreo, they're gonna go wrong. Understanding as much as you can about what the parents know, are expecting, or hoping for can really help you in these resuscitations. And I think these are the most important pre-delivery timeouts you're ever gonna do, not just for doing right by that family and by that baby, but also for your resuscitation team. People are anxious about these, especially when they have their own baggage and assumptions that they're bringing in, their fear. People really carry a lot of anguish about futile CPR, right? People really don't want to do chest compressions on someone that they think is going to die. And so this stay with me teamwork that you can do before these resuscitations is really important. And then if things go badly, and they sometimes will, be direct, be clear, and be kind. There's evidence that this is what Pam more than else is, that you told the truth, but you were kind about it. And remember, the one having the worst day. So I'm gonna wrap up here. You have some really phenomenal panelists who are coming up here, and I hope that you ask them and that you get to hear from them because they're fantastic. Thank you so much for your attention. It's really a pleasure to be here.
All the way over into this mic. Thanks so much. That was really good. You brought up so many practical things for us to do and think about. So we're going to be joined up here for a lively discussion by one of the people that you've referenced already, Jeanne Krick, who is a U.S. Army neonatologist and a bioethicist who's currently stationed in San Antonio, Texas, as the program director for neonatology at Brooke Army Medical Center. I was born there. She completed her NICU fellowship at the University of Washington and her ethics fellowship at Seattle Children's, and she currently serves as the chair of ethics for the San Antonio Military Health System, which is really quite large and includes more than the Army. And she's a consultant to the Surgeon General of the Army for medical ethics. And her research interests, we've already seen, include peri-viability, parent-physician communication, and uncertainty. And I asked her for a fun fact, and she said, well, I was crowned the tiny Miss California in a beauty contest when I was 18 months old. But that was the beginning and the end of my pageant career. Now, the second person who's coming up here to join us is Jessica Illuzzi. And Jessica is an obstetrician, so we really need her point of view. She holds a named chair as professor of obstetrics and gynecology and reproductive sciences at Yale. She's a graduate of Harvard, completed her OBGYN residency at Yale New Haven, and was named an NICHD Women's Reproductive Health Research Scholar. She completed a Master's of Science degree in epidemiology and and she is served as the Chief of Obstetrics Specialties and Midwifery at Yale New Haven. Now, she's particularly uniquely qualified as a discussant for us today because of her long on the NRP steering committee as the liaison from ACOG. And so we've always had her voice as the obstetrician and specialist for women. And her practical experience as a member of the perinatal team will inform her voice on the program this morning. Now, the fun fact about Jessica was that she spent the summer on Wednesday nights as the crew on a racing sailboat in Long Island Sound all summer. So she's going to join us today.
I guess I'll kick us off. So Naomi, thank you so much for your wonderful talk, as always. I'm always in awe of her, and she has been a fabulous mentor from afar for me for my entire career. So thank you publicly for that. My question is actually for both of you ladies. I'm really interested to hear your perspective on this because I have a feeling I probably know hers a little bit. So something that I struggle with in these kinds of conversations, we have these relationships that we build with these families where we're trying to guide them through these really challenging decisions that they have to make. And sometimes, to use your words, it's not that they won't make a decision, it's that they can't. And so they look to us to try to help them make that decision in that true shared decision-making model. Oftentimes, I am worried that I'm crossing that line between true shared decision, I'm helping integrate their values, and being a little paternalistic and saying, I think you should do this based on what I know about you. How do you balance that, and what practically do you do in those situations to help them through that?
I think that that's a great question, and I think the first question to ask yourself is to back up and ask whether shared decision-making is appropriate and whether it's what the family wants, right? So first of all, we know that from empirically that parents exist along a continuum of how much shared decision-making to be the way that decisions are made. And it's kind of a normally distributed continuum where some people say, I want the doctor to make the decision, and some people say, no, I want to do it, right? So not everybody wants it, is one thing. The other situation is that shared decision-making is appropriate in some situations, but in some situations, there's a right answer. And I think it is appropriate and necessary to make a recommendation when there's a right answer. I think it's also appropriate to help people when they're stuck. And the way I do that is saying, do you want me to help you? Do you need help with this? Do you want to for me? And I think just sort of getting over the awkwardness that feels and saying, like, you seem to be struggling, how can I help you with this? And if they say, tell me what to do, I think saying, based on what I've heard from you, based on what I understand, this is what I think feel right. It is my kind of approach to that situation.
Okay, what about the obstetrician's point of view in this?
Thanks for that question. So in thinking about this, it actually made, and hearing your presentation, it made me think back to my own training and my own experience being an obstetrician and then being a person giving birth later after my training. It made me reflect on how when I was an intern in my residency, at that point in time, OB interns were expected to rotate in the neonatal intensive care unit and actually see what babies look like in a variety of different circumstances and what happens and the important decisions that need to be made. And sometimes the very, very difficult courses that those infants experienced, like an IUGR baby versus a very preterm baby versus one with a congenital anomaly. And I feel like without that experience, it's really hard to even relate or counsel patients. So I just want to emphasize how important I think that is. And back to Satyan's comments earlier, not only do our pediatric residents need to have more time in NICU, neonatal intensive care settings, but so do the OB residents and the OB fellows. because it's only when you actually are able to see the angst and the difficult decisions that need to be made that you can relate to your patients when they come to you asking for some advice. The other thing that I think is important after having given birth myself several times is I began to realize that the act of going through labor and birth and those first few days and weeks after you give birth is such a profound experience that you have memories that are burned into you that follow you forever. I remember exactly who was in the room when I delivered my first child and the things that were said. And I talked to my trainees about that, my obstetric residents, about you realize, and even the medical students, like people remember the medical students who were in the room with them and who was holding their leg while they were pushing. And so I think that it's really important that we are thinking about these types of questions from that perspective as well. In thinking about, you mentioned, like how is the labor going to be planned? So when families are asking, what should I do in this particular circumstance, they're not only thinking about what's going to happen after the baby's born, they're thinking about how is my entire birth experience going to be changed because of the situation that my newborn is in. So, I think it's really important not just to ask, what's important to you and your values, but be able to be relatable and understand how profound this upcoming experience is.
Okay, well, let's go to Nicole at the mic.
Nicole Yamada from Stanford University. Thank you for this talk and touching on this topic, because I think second to neonatal resuscitation, my next love is the ethical dilemmas and challenges that we have in neonatology. I've read the question and probably have my own opinion, but would love to hear yours. This idea that actually Jessica has just touched on as well, which is wondering about how we actually are ever really providing informed consent to parents about the complexities of congenital anomalies or extreme prematurity, and knowing, I think, at least in my opinion, that we're not ever really able to express for families or seen these types of consequences and understand truly what it is required day to day to care for children who may have medically complex lives. What are your thoughts on how we're providing prenatal counseling and informed consent in that context?
So this might seem like a controversial answer, but I think that that's the wrong standard to hold ourselves to. I think, I am a parent and I had no idea what it was going to be a parent. And, Annie Janvier, who spoke last year, sort of talks about this. You don't pick a spouse that way. You don't buy your house that way. This idea that that the thing that's going to help parents decide what they want is this perfect accuracy about what it's going to be like, how it's going to feel. We could never provide that, and it's not clear that that's what they want or that that's what they need. I think there's growing evidence that parents approach these decisions in this very intuitive way, and that sometimes the information we give them sort of shapes that decision. But I think we have to relieve ourselves of this obligation of trying to do that, because we couldn't ever do it.
If it's okay to add a little bit to that, I think part of getting at that is this conversation around uncertainty. You brought up uncertainty, and I think a lot of what we're trying to do in the prenatal consult is alleviate some uncertainty. The problem is the uncertainty that we're trying to alleviate is purely scientific. We're trying to give prognostic, diagnostic, treatment, statistics, answers, information to help inform the parents. That's a little bit about what the parents are concerned about, but they're really looking at more like the practical and existential degrees of uncertainty. What does it mean to be a parent of a child with a critical congenital disease? What does it mean to spend the first year of their life in the NICU undergoing multiple surgeries? That's not a question I can answer. I don't even know that it's a question that another parent can answer, because they're not in that parent's shoes. So all that I can do, I think that getting to that point has kind of given me a little bit of given me a deep breath. I can give some information, but I don't think I can get to that standard of what is true informed consent, because I don't actually think it's possible.
Any comment, Jessica? Okay. Well, Go ahead, Marilyn.
Thank you so much. I love your ways of trying to make things simple and standardizing things. Walid Nagar from Halifax, Nova Scotia. My question to you is, I'm going to the consults around antenatal consults for the congenital defects in general. And the complexity of it is the few numbers or the few literature there. I feel more comfortable counseling around the age of viability because I have a lot of information and so on. When it comes to this group of the congenital defects in general, I feel sometimes that it's like a blind leading a blind. And what happens is it ends by having 3 camps in the room, the surgeon or the neurosurgeon, who's always very optimistic because they can, the MFM, who's something in the middle, and me, or the neonatology, who can be very pessimistic, of course. We don't have much information. All of us individualized way of thinking and collecting data. Now, I'll come to the main question here, which is sooner or later, whether we advocate for it or not, is the role of the AI and of the artificial intelligence, whether for the physicians or medical care providers to use it or the parents to use it. Now, I don't advocate for it for sure because I like the human interaction in such a situation, but what's your advice in this case, or how can we handle this, the development of the growing role of the AI?
I'm going to back up and make sure I understand the question and also address the first part. I mean, I think to your point about how do we even get on the same page in the setting of like these very unique situations where you have multiple specialists who provide care in a very different way and getting on the same page. We spend at our institution a lot of time talking. And ideally we do that before any one of us has really gotten into it with the family, but especially around things like a bad CDH, we will really try to talk a lot ahead of time. To clarify your question about AI, are you talking about specifically the ability of AI to anticipate maybe with more precision than we can what the outcome is going to be? You know, I think there's going to be 2 things. There's going to be, can the AI sort of capture data in a way that we can't to offer something? And what's the sort of validity around that going to be, right? Because to the question about like informed consent, maybe it could get to a point where it could predict survival. It could predict survival with measurable, you know, like morbidities. But I think it's much further from being able to predict what's it going to be like. And so I'm not hearing in our world even discussion about using it as a tool to support sharing prognostic information with families. I think it's going to be an internally facing tool much sooner, right? Where maybe it can help us. You know, I use it already now before I do prenatal consults as a faster way to synthesize the literature around a condition I don't know a lot about, right? I'm already doing that, right? What on earth is Yule's anomaly? I could, you know, go to PubMed to find out and come out 3 hours later, or ChatGPT can probably give me something pretty good in 5 minutes, right? And so I think it's going to happen with evolution. Then I think something terrible is going to happen, and then we're going to have to like go back and rephrase. But I think whereas there are other applications of large language models in medicine that are here and coming, I think we're pretty far from that scenario because of the every single case is different kind of problem. I don't know if you guys have it different.
Well, the only thing something that you said just resonated with me about how, you know, technology is not necessarily going to help parents understand what it is going to be like, right? Because often that's what they're asking us when they're looking to us for guidance. So I think it shows the critical role that we all play in helping understand what parents are wondering about and just what things are going to be like. I think we have to acknowledge our role in actually determining what it will feel like, right? In the way that we coordinate with each other and prepare. Because, you know, like you said, if we didn't include OB in planning the delivery and the immediate time afterwards, it could be quite different, right, than we, as neonatologists, would expect it to be. So it's just such an important to have everyone around the table meeting with the family to determine what it is that they're looking for and figuring out what our role is in determining what it will be like. I know that technology can't really fill that gap.
And it's so important what you said, that everybody's in the room talking about it together before the parents are involved, so that you're all on the same page and they don't witness a lot of the before you come to an agreement on how to deal with the parents. Okay.
Can I just say one other thing about AI and where I think it might play more of a role in something like prenatal consultation? Some of the most interesting things I'm hearing about, for example, in like ambient AI, is when it has the ability to detect things in the patients that we're not picking up, right? So will AI in the future help with relational competence? Will it help say, like, you're making this mom mad? And like, you might not have picked that up with your ears or your eyes, but like, I can tell that this mom is getting mad at the way you're talking about her baby, right? And I think that's an area where that will probably come sooner than we think.
How interesting. Hey, Nathan, what's your question?
Hi, Nathan Sunger from Texas Children's and Baylor. So first of all, thank you so much for the conversation, for the organizers for having this topic here. I think it's been really great. My colleague and I have been talking about some ideas we can take back immediately and implement as well. But one of the things about where I work is that we have a large fetal center. And the first thing I thought about in listening to all yours is, fetal surgery, fetal interventions, it's not only about more precision about knowing, but now we're intervening. And it's not just neural tube, it's fetal endotracheal occlusion, where we're delving into cath procedures, gastric cesis repair. These are stuff that are coming down the pike. And how do we now counsel in situations? Or is there even some situations where we're not even being asked to consult in these situations because it's so heavy in focus in our fetal center? I feel it very heavy and focused on the surgeons, the interventionalists, the OBs, of course, the MFMs, but and by the way, Neo also might actually show up and help us. And how do we think about that as neonatology? First of all, and so just taking your concepts and maybe saying and speaking a little bit to how that would translate to when we're being consulted for fetal interventions.
I think it's a really important question, and so part of the problem is if you've seen a fetal center, you've seen one fetal center, right? And everybody's building these a little bit differently. And certainly, I came to my own institution at a time where like neonatology was not part of the story. This was something that MFM and surgery were doing. And I was like, why aren't we at the table for these things? And showing that we have value in this starts appreciating expertise. So getting to know your OBs, showing that you're interested in their care, showing that you're interested in the surgical care, and building those programs with intentions. Nobody should have a fetal surgery program that doesn't involve a neonatologist as part of the leadership and a model for neonatologists being part of the consultation. I'm not saying that's the current state, but so you're right. I mean, like if the model has to be that neonatology is part of the counseling around fetal intervention. Because the other thing is that I think being able to describe what's the outcome like without the fetal intervention, right? We're the ones taking care of those babies either way. And so building your programs with intention, if you have the opportunity, and then if they haven't been built that way, really taking the time and sort of approaching the geopolitics with the sensitivity that it takes to get yourself into that story. I don't know if that's enough of an answer, but.
No, and just to clarify, it's even as we're in there though, what I feel like for the parents is, because there's so much on the disease, I mean, one of the first questions I answer when I go to those fetal consults is, who the hell is neonatology? Because they're so focused on the heart disease. They know who the cardiologist is. They know who their OB is. Who the hell are you?
I start most of my consults with, do you understand what a neonatologist is and why you're talking to me? I mean, I start with my consults that way.
Yeah.
Okay, let's go to Satyan.
Naomi, that was a wonderful talk, and especially the publications that all of you put out are very helpful in the middle of when you're doing a fetal consult and you don't know what to do. You Google and then you find a paper with nice color-coded chart. It makes my life. So thank you so much for that. My question to all three of you pertains to social media use by parents. It's not uncommon, you go to a tough consult, and then before you know it, it's on Facebook, it's on Instagram with pictures and everything. And it gets even more complicated when half of our nurses in the NICU are following the parents on Facebook. And there's this whole thing discussing what you talk to the mother in a confidential way about prognosis. So during these instances, do you completely ignore it and do what you need to do, or how do you adjust to this reality? Because there have been a few instances when, also from the chancellor's office, that do you know that this thing is online and is this really what you said? And especially pertaining to trisomy 18 and things like that. So how do you deal with parental use of social media, and how do you approach that in ethically complex patients?
It's a great question that I don't know that I have a perfect answer to, obviously. What I can say is that I feel like I have an expertise in being able to keep my mouth shut because I'm in the Army. So I'm very good at that. So the way that I look at it is that this parent is telling their own story. They have to shape their own story. And in their story, sometimes they need a bad guy. And sometimes my role in that story is that bad guy, even though that was never my intention. My goal was to partner with them, to give them information, what have you. So first step is to acknowledge that this is their journey, not about my journey. This is terrible and awful. I admittedly will probably go eat a pint of ice cream to get over that myself and talk it through. Step two is how then do I repair that relationship if it's one that's ongoing? So a parent who is in our NICU posted something, nurses saw, brought it to our attention. I don't avoid it. I think it's important for us to have a sit down in a very non-confrontational manner. So the natural inclination is make sure you have plenty of witnesses when you go to talk to this parent. And I push back against that because I think it's more important to focus on the relationship and say, hey, you know, I noticed this. But instead of focusing on, hey, you said all these bad things about me, I try to shift the focus to, I think there was a little bit of a lack or a miscommunication. I want to make sure that I'm addressing your concerns. What are your concerns? How can I better serve those in this moment? And I really try to just spin it back to that parent is having the worst day of their life. This is the way they dealt with it. This is their story. I'm a little part of it. It hurts and it's real and I need to deal with that in a way, but that's how I've tried to reframe it myself.
One other thing about that can be important. I mean, certainly, I completely agree. You're not going to change their opinion, especially once they have it, and you're not going to keep it off social media. And if the nurses in your unit want to follow them on Facebook and carry that burden, like, there's nothing you can do about that. But I think sometimes where we go wrong and where we could have prevented it from happening to begin with is in reading the room better about which parents actually are going to get anything out of a frank review of the bad outcome, right? So some parents are going to come to you with zero interest in the survival outcomes for a baby with trisomy 18 and the hypoplastic left heart, right? And they already know what they're looking for, and they know what they're looking for from you. And forcing them to hear how bleak the prognosis is has done nothing except fracture your relationship with that family. And that's all you've achieved. And so I think some of the ways we can avoid that is spend more time at the front end, the tell me more. What are you hoping to get out of this discussion? What are you looking for from me? What information do I have that you want? And it doesn't mean that I offer you choices without considering the diagnosis of trisomy 18 because they can't do that. But if you've already been to the internet and you've already read all these things and you already have decided what these outcomes are, I might not talk to you about the outcomes. And that's okay. And I might feel like I didn't really do my reviewing everything, but that's okay. Some of what we can do is spend more time understanding what that family was looking for so that we haven't introduced that friction to begin with.
Yeah, and I'll just add, I mean, we've had a few episodes similar to that where patients have posted things online about their either birth experiences or conversations that they had with care team members. And I really think it's a very reasonable and perhaps a good idea to try to talk with them afterwards about that, to try to understand, you know, where their concerns are coming from and their dissatisfactions coming from. Because if you're going to continue to have a relationship family, you want to be able to try to have a more positive interaction going forward. So I think those conversations are important.
Lily, you're up.
Thank you. Lily Liu from UIC in Chicago. Thank you, Naomi, and thank you to the panelists for this important discussion. This is another real-world issue. So I know that, Naomi, you talked about being born in the right place where they can offer the services that you are interested in. And Marilyn, you mentioned how important it is to get everybody in the same room, but not every baby is born in a place where everything can. How do you fold in discussions about what insurance might cover, what a hospital might cover, how it might impact a family's finances, and can we do some of this through telemedicine, or how essential is being in the same room?
So we do more and more of our prenatal consults via telehealth. That, it came out of necessity of the pandemic. But Michigan is a huge state without a lot of specialty referral centers. And what I've learned is if I can talk to these parents in a tiny consultation room with their 3-year-old twins bouncing off the walls, or they can be at their home in their Upper Peninsula while those twins are watching Bluey, we're probably gonna get more done via telehealth, actually. Or if that allows me to get both parents where, I wasn't gonna get them both. I think a lot of this can be done via telehealth and probably get the quality of interaction that you want. And there's some literature, it's limited, but there's some literature starting to show this. We're doing it more and more. There is a little bit of we are very agile with Zoom, and parents aren't always, but I think that we can be flexible with this idea that I couldn't possibly form a close connection and talk about hard things if we're not physically together. The issue around what do we have to offer, do we have all of one issue, and the thing that part of the reason I felt so strongly about writing the AP statement was it's the delivering in a place that will philosophically do what you want. And I think the age of our hospital doesn't offer resuscitation to babies with trisomy 18 full stop because we don't do that. I think that should be phasing out. But if the service really isn't available, I think these are frank conversations with parents about what's the most important thing to you. Is it staying together as a family? Is it delivering with your home OB? What are the things that are most available to you? The insurance stuff is, as much as you can, trying to sort that out up front. The only place I really hit a wall with this family can't get the thing they want because insurance won't pay for it is around genetic testing. That's the place where I finally we just we couldn't decide about this because we couldn't get the fetal whole genome, is where I find that we are getting the most hung up on third-party payers or sort of limiting our ability to do our job well.
Well, I think we have to close out and have lunch now. But it's hard to stop, isn't it? Because we're really having so much fun talking about these complex issues every day. So enjoy your lunch, see the posters, talk to our educational partners in the hallway. And is there anything I left out? Be back at 1:30. 1:30 sharp, we start again. So thanks to all our panel and to Naomi, thanks so much.